Thank you, and welcome to our lecture and topic tonight. I'll be discussing sports-related injuries of the foot and ankle. Some of my disclosures, you will see product that is used within some of these slides. We'll get moving forward. So looking at the agenda, I kind of tried to take a large topic and narrow it down, as we know that the foot and ankle is a very complex thing. And I do a lot of specialty in sports surgery, sports reconstruction, and management of sports injuries. So I've taken some of the top related injuries that I see in my practice and narrowed them down. And for those of you who want to gain a little insight in me, I am from Cleveland, so I always start out with a Cleveland Browns picture. So cheers to all of our Cleveland Browns football fans. So I think what we need to do is really break everything down and look at what defines an athlete, right? So some of us would think of athlete like a young, active individual. Some of us would think of a marathon runner, an ultra elite athlete. The way I look at athletes is anyone who enjoys exercising and getting out and playing sport, whether that be pickleball, golf, soccer, volleyball, etc. So to me, an athlete can be a person of all ages, and that's why I think this is a little bit more encompassing for the general public and not necessarily our high school elite athlete or our college athlete. So what I like to do is I'd like to start from up in the leg and work down into the foot. So what we'll do is we'll discuss Achilles tendon ruptures right out of the gate. I will warn you there are some surgical videos listed in my PowerPoint presentation that may be slightly graphic, and I'll give you a fair warning on when those surgery videos are coming up. So when we start to look at Achilles tendon ruptures, what are they, why do they happen, and what do we do for them long term? So looking at Achilles tendon ruptures, I mean, typically we see some etiology. This is typically more males than females and always found in our running and jumping. And when you break this down, if you look at the forces behind Achilles tendon injuries, this would make sense. For those individuals who are slightly elder in age and not as active, there's certain medications can actually cause injuries to the Achilles tendon. And that's why I added this here too, because this is a catch-all for anyone, not only an athlete, but someone who's active out and hiking and running and jumping. As a physician, I have to break down the reason why the Achilles tendon ultimately failed. So when I start to look at a list of things, which I've provided here on your screen, you look at some of the intrinsic and extrinsic factors. We look at weight, we look at age, gender. What is your foot type? What is your foot structure? How powerful are the muscles in the back of the leg? And have there been issues along the way where basically training mistakes? You thought you were doing the right thing the whole time when ultimately you're actually causing further damage and setting yourself up for failure. The biggest thing I see when I have a patient who comes into my office complaining of an Achilles tendon injury, the first thing they say is, hey, I feel like something popped in my ankle, or I felt like I got kicked. And you look around and there's nobody behind you. So what we do is we do this test. It's called a Thompson squeeze test. And you can see this image right here. And on the image showing the foot on the left, this patient's laying on their belly, is very swollen. It's starting to get a little black and blue. And by squeezing the calf muscle, that foot's not moving. Where on the other side, or the contralateral limb, you can see that that foot is plantar flexing, and we're concerned that there's Achilles tendon injury at that point, and that's when we start to either work into advanced imaging or we start to discuss some management moving forward. So once I've had the ability to identify that there is an Achilles tendon injury, I have to start working through at what level can this rupture. So as athletes and people who do extensive walking, you can tear the Achilles tendon at multiple different spots. Typically, it's called the watershed area, and it's that 6 centimeter proximal rupture site just above where it says 72 to 73%. This is where when people, play basketball, they feel that kick, that's usually where these sites rupture. So now that we've identified the problem, we've identified the location, we start to talk about whether this is more of a surgical management or is it more of a conservative care. The nice thing with Achilles tendon injuries is it's extremely well studied, and this is probably one of the most quoted sports literature articles for Achilles tendon ruptures, at least in my practice. So it's out of the American Journal of Sports Medicine, a very reputable, respected journal, looking at 7 level 1 trials. And for those of you who understand research, level 1 is the absolute highest level of research that you can get. And when you really look at this stuff and break it down, both showed that they were appropriate in treating non-operative versus operative outcomes and getting appropriate outcomes. However, the operative group had a significantly less re-rupture rate and less complications. So let's say you and I had discussion and you ultimately said, you know what, for me, I'm a better surgical candidate. the next thing I would do is bring you to what could possibly go wrong, right? So surgery is definitely a good fix for a lot of things. However, surgery carries a lot of issues as well too. From the get-go, we're concerned about wound complications. On the back of the leg, it's a high tension, high stress area. You can get a wound complication that can happen back there. There's also a very large nerve that runs across the back, and that can cause injury or damage. People can develop reactions to foreign materials, sutures, suture anchors, etc., that are sitting in the back there, and that's what we ultimately use to reconstruct the Achilles tendon. Looking at the issue of complications, you start to really realize that the risk of complications is actually quite low. So when you look at the Achilles tendon rupture literature, you're looking at a small increase between open versus minimally invasive, and a deep infection rate of no higher than 3.6%. So this is actually quite low. The nice thing with the surgical aspect, though, is definitely operative times increase your return back to sport that much faster. So this is a pretty graphic video. What this does is it shows an open repair of the Achilles tendon. So this is something called a box weave stitch, and this image or video on the left actually shows a full rupture of an athlete's Achilles tendon. And what we do is we go in there and suture it back together and ultimately put it back together with these sutures. And then that image on the right demonstrates the video showing that the Thompson squeeze test has ultimately restored the anatomical function of the Achilles tendon, getting that athlete better and ready to go from a healing standpoint. So those of patients of mine that are potentially on this call know that I am very much an evidence-based medicine guy. I'm very much a literature nerd. This is what drives me, and this is what drives my practice, because I'm always looking for the most successful outcomes. I follow this protocol to a T, and this has been put over and over and over again by hundreds, if not thousands, of Achilles tendon injuries in athletes and trainers all over the world. So looking at this, we all know these athletes that have had these bad, horrible injuries. And what I always tell all of my patients, no matter how athletic you are or how non-athletic you are, you're looking at 6 to 9 to 12 months for a full recovery on Achilles tendon ruptures. These are horrific injuries, and I don't wish them on anybody because they take a lot of time. There's only so much we can do from a surgical standpoint in the reconstruction, and then we have to do what the body does best and let it heal itself. So this is a great study out of 2016 from the British Journal of Sports Medicine, indicating that the average return to low-level athletics was 6.4 months. Kevin Durant, who's pictured here, it took him over 12 months to kind of come back and play full functional basketball. So you got to keep that in mind when you start looking at some of these big foot and ankle injuries. Moving a little further distal down into the ankle sprains. One of the most common things that we see as foot and ankle surgeons in our practice. And really when we start to look at the reasons why is we all have injuries and we all have underlying biomechanical issues that can cause some of the issues. We start talking about playing surfaces. I see this a lot in my volleyball players. I see this in my soccer players, uneven ground, people with jump athletes who land awkwardly on someone else's foot. There's all kinds of things that we have to look into. But this is a list of the most common epidemiology of ankle sprains. You're looking at basketball, football, and baseball. Okay, and a lot of that, people would say baseball, a lot of that it's rounding the bases. You're making that turn and you're right over the top of the bag. It's actually really quite common. I would add volleyball in here too. I do see a lot of volleyball players, probably 1 or 2 a day with these types of injuries. So, and of course, our favorite things, high heels. Okay, high heels are probably one of the #1 reasons why people sprain their ankles. And I love hearing the stories from my patients and getting the info on how this happened and why it happened, because it's always a great story and it really lightens my day. So patients come in with this and they say, hey, you know what, doc, what's going on? This is what my ankle looks like. Here's what I did. And when I see this ankle, I can definitely tell it's a very angry, it's a very upset ankle, but I have to start to break things down. I have to look at why would this happen? And we start to look back on, was it high heels? Was it a sports injury? Because in my head, I'm already starting to formulate what my diagnosis plan will be. And when I see an ankle sprain, these are the potential things that it could be. It could be an actual sprain. You could be a chronic sprainer, meaning you roll your ankle multiple times. You could have some underlying instability that you've never known about. You may have broken your ankle. You may have the chip in a cartilage and you may have fractured your foot. So lots of things can happen. So we move on from, all right, let's start looking at the surface level. We start to look, are there any nerve injuries? And when we look at this image on the lower left, you see how complex the nerve structure actually is to the foot and ankle. In most people, they develop something called neuropraxia. And what neuropraxia is it's elongation of the nerve, and it causes the foot to go numb or tingly. And for those patients who've rolled their ankle, I'm sure they're shaking their heads right now saying, yep, I've been there, I've had that, I've done that. I too have done this multiple times, and I know exactly what I'm talking about because I've seen this side of where I'm at. Now that I've identified the surface level, I'm diving deep down into the ankle. And when you look at this, these are all of the different ligaments in the foot and ankle. And this is what makes the foot and ankle extremely complex and hard to diagnose and manage sometimes. This is why I love this. This has always become a puzzle to me, right? We walk on our feet, we stand on our feet, we run on our feet, we dance on our feet. Trying to get all these little intricate bones, ligaments, tendons, muscles, and nerves to balance in place is always something that's been something for me. I was a soccer player growing up, so I've had multiple injuries. So looking at the ligaments, now we're going to move into the x-rays. And that's where a lot of people think, oh, it's just a sprain. When I get an x-ray and there's actually something else going on. There's a fracture, there's instability. So we run you through all these different things. So moving into, let's say, just the outside aspect of the ankle. These are the different types of ankle sprains someone may potentially undergo. So a ligament called the ATFL, or anterior talofibular ligament, is hands down the most common injury. And this is what most people, when they roll their ankle, this is what they injure. When there's a higher energy, such as a fall, hiking, etc., you can do a dual combo of the ATFL and CFL. Very rarely do we an isolated calcaneofibular ligament, or CFL. And then we get into those syndesmotic injuries, or high ankle sprains. And those of you who are college sports fans can hopefully identify this athlete down here on the playing surface. It's Tua Tagovailoa. And ultimately what happened is he had that high ankle sprain, tore the ligament, and everybody knows the surgery that ultimately was underdone on him and got him back up and playing. So we really, as a foot and ankle provider, have to dive down into all this stuff and really figure out which of these solitary ligaments were damaged, because that ultimately may change our treatment algorithm quite a bit. So if you come into me and you're a first-time ankle sprainer, you really have no gross instability, I'm going to move you down the road of conservative care. Traditional RICE therapy, rest, ice, compression, elevation, absolutely is key and critical to getting that swelling and inflammation under control. We can use anti-inflammatories such as ibuprofen, Motrin, Aleve, topical anti-inflammatories, etc. A lot of the times I'm going to move you into either a sports brace that will fit inside your tennis shoes, or I'll get you into a walking boot. It looks like a big ski boot. They're called cam walking boots. And what these do is they allow the body to kind of take over, go through that inflammatory phase, get everything under control, and ultimately heal you. And then eventually we start aggressive rehab. So that's the direction that most physical therapists are now going, because there's been some great literature that's come out talking about aggressive physical therapy versus chronic immobilization for ankle sprains. This is probably the most common question I get from all of my athletes that I see in my practice. Doc, would you recommend the trainer to put me in a brace or tape my ankle? And this is a great article in 2012, and I still quote this article to today, and just really note that there is a significantly higher availability to get you back to sport that much faster without retaping from quarter to quarter or half to half by using a sports brace. Sometimes I do have to have my athletes upsize on their brace, or scratch it, upsize on their shoes, but most of the times they can fit this in their regular soccer shoes or volleyball shoes and get back out there on the field and court that much quicker. Let's say you're that chronic ankle sprainer, and we have to move you on down that road. Acute repair of an injury is really quite rare, and I advise against it almost 100% of the time. A lot of times we can get these things to heal on their own, but a lot of times these do come back with chronic injuries, and we start to look at the numbers, which I'll show you on the next slide, and we start to talk about ligament reconstructive surgery and ankle arthroscopy, or sticking a camera in your ankle joint and looking inside to see what's going on. So you look at some of these numbers. 73% of all ankle sprains injure the ATFL, and that's kind of what we had talked about before. 4 out of 5 will have chronic instability after 1 year, and ultimately long-term, 2 out of 3 patients will have longer term injuries such as degenerative joint disease because the ankle motion isn't normal. So now that we said that, okay, we need to move down that road of surgery, what is our outcome, right? So 50% of a traditional Broström repair, which means a ligament repair with just suture, will ultimately break down and require further surgical management. If you look down in this lower left-hand corner, you can see that 30% of people or 35% of people will ultimately require a second surgery, and 60% of people with multiple ankle sprains will go on to joint disease, meaning that down the road we may have to replace their ankle, we may have to do other revisional surgeries down the road. So I go back to my evidence-based medicine and said, why would I start to push the envelope? Why would I use anchors and bracing? And these are just a few of the literature articles published in just the past 2 years that demonstrate the efficacy and the way technology is helping us drive patient outcomes. And we really start to look at these from a multi-level, multi-standpoint. And this is a meta-analysis which I use all the time, just kind of looking at things. And the reason why this kind of pushes on us is it allows us to get our athletes up and moving that much faster. So when I was a fellow back in 2011, we would do lateral ligament reconstructive surgery and then keep them in a cast for about 6 weeks. Now I do lateral ligament reconstruction, I use an anchor, I keep you off your foot and in a boot for about 7 to 10 days, and then I get you up and get you going relatively quickly. And a lot of that has to do with some of the advances in technology. Once again, I'm sorry, a graphic video or a graphic image, but these are some of the surgical options. And I perform all of these, and a lot of them are very instrumental based on number one, age, number two, laxity, and what your ultimate outcome is, what you'd prefer. So it's nice to have this in my handbag, as I can go into any which one of these and drive an appropriate patient-driven outcome based on whether I want to do this all arthroscopic or do I want to do this open with anchors and suture augmentation. So it really gives me the availability to attack any type of ankle sprain, any type of ankle instability for any patient that's out there. Like I'd kind of hinted at earlier, this is kind of my standard post-op course, 7 to 10 days off the foot, formal therapy at 4 weeks. We get you back into sports or up enjoying the things that you like to do right around 10 weeks with no sports brace. So going back to, hey doc, I sprained my ankle. This was the original picture that I had shown you. And if you look at the x-rays, x-ray looks very good relative to the image I showed you with all the bruising. We start to go back to those ligaments and think about what's going on and identify that this is mostly a syndesmotic injury, that high ankle injury. And once you get to it, these are ultimately what has to undergo, is because that stress is radiated through the bones all the way up towards the level of the knee and caused a fracture at the level of the knee. That's how much energy is sometimes involved in these routine ankle sprains that can potentially go misdiagnosed or underdiagnosed. This is a patient of mine who ultimately had to have a cable system implanted in their ankle to help stabilize the ankle from them stop rolling. Next, we're going to move into navicular stress fractures. This is something a little less common. However, it sometimes seems to manage in my practice quite frequently. And a lot of times this is sent in by athletic trainers who have been taking care of patients for some time, and they've tried a plethora of things and they just can't figure things out. So navicular stress fractures are actually really quite hard to diagnose, and I miss them all the time, I'll be honest. And I ultimately end up getting those advanced imaging studies, and lo and behold, here it is right in front of me. So these are very challenging, very difficult injuries to treat, but one of the most common stress fractures in all in foot and ankle. So now I'm actually looking for this quite often, and over the past 5 to 10 years of being in practice, I specifically look for these injuries now in my athletes. So I usually see these in my sprinters, my distance runners, and my basketball players. And typically they're young males who just have this nagging midfoot pain. And if you look at the underlying cause and why these patients can have this, is we start to go back at the elementary level or rudimentary level and look at the blood flow. Okay, blood helps keep things alive. And this bone in particular, this cashew-shaped bone called the navicular, has a lack of blood flow right in the central aspect of the bone. So, looking at this, a lot of times this is poor jump mechanics, or people have a tight calf muscle, short first ray with a long second ray is more of a mechanical thing with your foot. It's just dealt with the bones. Reduced range of motion of the ankle joint can set people up for these. The one thing that I always kind of reference is the end spot, right? So they have pain to the navicular spot or end spot, and it's this pain that's right in between two of the big tendons on the medial aspect of the ankle. And when you push on this spot, the patient wants to jump right out of their seat, and you know right then and there that you're dealing with a navicular stress fracture, and you've got to get advanced imaging on this. So a lot of times you get plain x-rays and you're not going to see much, but they have this pain. So that's when you start to roll into the MRI, you roll into a CT, you start to look at some of those more specific things, which breaks it back down to me to say, okay, you've got all this fancy data, identify it and tell me what to do. Okay, so when I get an advanced imaging, MRI, CT, in my head, these classifications are already kind of running through my head. Okay, here's a grade 0.5, here's a grade 3. How am I going to treat that? Because at the end of the day, that's what worries the most to you as an athlete. That's what worries the most to your coach, your parents, and your teammates, is how is this going to be managed and how is it going to get treated? The problem with navicular stress fractures, if you look at the non-op return to sports, or RTS, 22.4 weeks of return to sports with non-operative treatment. This is a whole season for some athletes. This can be absolutely crippling to the team, the patient, the athlete, your psyche, because when you start not to heal and it takes this long, you start to play games in your brain and in your mind. If we can go this road, we typically try bone stimulation or ultrasound to help increase the blood flow to the area. We're working on getting everything back together. Vitamin D, even though we can get vitamin D from the sun and we live in Arizona, shockingly, a lot of patients who have these stress fractures or stress injuries are low in vitamin D. Some of the other information would be shockwave therapy, which is a little controversial in the literature, but it is absolutely listed in the literature. For me, what I've seen in my own practice is about 50% of my athletes will fail non-operative treatment and ultimately put them back into the role for operative care. So if we talk about operative care, return to sports is 15 weeks. We talk about non-operative care, we're looking at 22 weeks. So quite a difference. You're talking almost a 2-month difference. So that's why I like to kind of push these patients a little bit towards the operative standpoint versus moving them down that non-operative road. And once we've decided on an operative care, it's up to me to kind of look at the fracture pattern and ultimately decide on which direction we're going to go. Very similar to a lateral lig, we're looking at a post-operative course that is a little bit longer, but my hopes and goal for every one of these athletes with these types of injuries is to get you back to sports at 4 to 6 months. So, for example, this is a patient of mine, basketball player, 2 weeks history of left midfoot pain, worsened with weight-bearing activity. As soon as they get off the foot, they have no pain. They walk with a limp. It's very tender over the end spot and a little bit of cystic mass. If you get an x-ray, you're really not identifying any major injuries or bone cracks. There's no very obvious fractures. So what we do is we pull the trigger on advanced imaging. You really start to see these images, and this bone in the upper left-hand corner seems to be very white in nature when the rest of the other bones are very gray or very black in nature. And that's very indicative of a navicular stress fracture and an area of concern that would be alarming for me. Breaking this down even further, you see a big crack through the bone, and ultimately what this patient ended up doing is having surgical reconstruction. We were able to get them back out playing soccer or playing sports within about 4.5 months with this patient. So moving into fifth metatarsal stress fractures and fifth metatarsal fractures in general. These are probably one of the most commonly seen fractures that we see in athletes of all ages, all levels, and all calibers. And the reason for it is there's multiple different ways that someone can break or damage this bone. So when you've been diagnosed with a fifth metatarsal fracture, you can have a head and neck fracture, which is identified and demonstrated here on this image, close to the toes. You can have a shaft fracture, which is the central aspect of the bone, or you can have a base fracture, which is the part of the bone that sticks out of the side of the foot closest to the ankle. I would tell you right now, the majority of these do very well with non-operative care. And typically they don't displace or they don't move. When you start talking about high-level athletes, running, jumping, lots of stress on their feet, you start to talk about the stress fracture. Everybody's heard about the Jones fracture and how debilitating that injury can be, and then we'll also talk about the avulsion fracture. And the avulsion fracture is typical in ankle sprains, and this is the one that I find most common when people roll their ankle and say, oh, by the way, I rolled my ankle, and I come back and say, you broke your foot too. This is the one that we always see all the time, okay? So, and this demonstrates the difference between the head fracture, the shaft fracture, the Jones fracture, and that tuberosity. So, looking at fractures, like I said, one of the most commonly fractured bones in the foot, especially with that rolling ankle motion or chronic repetitive stress. And a lot of that is due to the poor blood supply, going back to what we had discussed earlier with navicular fractures, and that 1/3 fracture. And when you have fractures that have specific names, i.e. the Jones fracture, there's usually something historic or something that's important that we should pay attention to. Typical fractures just, hey, you know, it's a shaft fracture, but when you have a Jones fracture, that means there's something to it. From a conservative standpoint, from a fifth metatarsal fracture, typical boot, immobilization, weight bearing as tolerated will be more than sufficient to allow the fracture to ultimately go on to heal. Sometimes this does cause a significant delay in back to sport and get you back up and get you going, get you moving. The repetitive stress fracture, stress injury, is when a bone just breaks out of the blue. You're just running, jumping, you don't fall, you don't roll your ankle, you just feel a snap and all of a sudden pain. That's what this is. And these stress fractures can be quite challenging to treat because of the fact that we're dealing with mechanics, we're dealing with stress overload, and a lot of times these ultimately have to go into surgical management. Otherwise, this fracture is just going to keep reoccurring, and the injury that you had maybe during your freshman year will return back in your junior year, which will return back in your college years. So this is not something you want to keep missing over and over and over again. Moving into the avulsion fracture, which I'd kind of briefly hinted at before, you can see in this picture on the upper right as well as the lower right, it's a crack right through the bone right at the base. And a lot of people say that this is secondary to a mechanism of the muscle pulling the bone off. And if you think about an ankle sprain, everything gets pulled really tight, and ultimately the muscle and the ligament pull a piece of bone off. A lot of times these stay very stable, they stay very close to the bone together, and ultimately you don't have to fix them. However, some of the times that these things do migrate, they shift, they rotate, and occasionally we do have to go in there and put a screw in there, which is demonstrated in this. And there's several different ways we can go about this. Going into the Jones fracture. And like I said earlier, Jones fractures, when they have names, they're very specific and very particular. You can see this Jones fracture, and this is what a lot of athletes really suffer, and this will wipe them out for an entire season if left untreated. The problem with Jones fractures is right here listed. High risk of delayed union, meaning it doesn't heal within the first 6 to 8 to 10 weeks. Non-union, meaning it doesn't heal at all, and or a refracture of the bone itself. So typically when I see a Jones fracture, it doesn't matter, at least in my mind, what type and caliber of athlete you are. I almost always recommend surgical management. And the reason for that is strictly because of what the literature has told me about the risk of how long it's going to take you to get back to enjoying the things that you like, and how quickly I can ultimately get you back out there with a screw, because at that point I rely on the screw to do the work while the fracture heals. And I've been successful at getting patients back out on the field within 4 to 6 weeks following ORIF or repair of the bone versus waiting 8 to 10 to 12 weeks of getting you back out. So this is a 43-year-old, very active male who is active in mud runs and CrossFit. So obviously we're looking at someone with high level of stress, no previous pain, ultimately causes a stress Jones fracture. And as we just talked about, stress fractures and Jones fractures are hard in themselves, let alone when they're a combined injury, right? So ultimately, at the end of the day, what my recommendation for this individual was screw fixation. So getting into this is our operative and non-operative, return to sport 4 to 18 weeks with a screw versus 9 to 22 weeks non-operatives. So we're really looking at a lot of issues. All right, hitting the home stretch here, folks. Moving down into the toes, so sesamoid injuries or turf toe injuries. We see these quite frequently, and these can be a bear to deal with sometimes. Those of you that have had turf toe know how painful this is, and every single step that you take, you experience big toe pain on the underneath aspect of your foot. So we typically see these in our patients with high load and high repetition that runs through the toes, sprinters, dancers, and football players. And for football, a lot of it is offensive linemen and defensive linemen who are down in a three-point stance and pushing off of their toes and really digging their cleats into the dirt and really kind of going after it. I do see a lot of this in dancers because of that repetitive push-off and stress, especially point dancers and in ballet. So looking at this, I mean, stress injuries, 83%. I mean, this is a huge, huge number of patients. So a lot of this, if there's any parents on this conference call, you'll hear your young athlete come home and say, you know what, mom or dad, my foot's really starting to hurt. I mean, they can't recall an injury, but all of a sudden it's to the point where it's sidelining them out of their sport. These are some of the things that you have to start to consider, and especially our dancers. Look at that. 38% of dancers will develop some sort of turf toe and or sesamoid injury. Looking at these from a conservative standpoint, you really kind of get moving down the road. Most of the time we can treat these non-operatively, upwards of 90%. 10% of the time we have to go in surgically and repair these things. But look at the average return to sport, 161 days. I mean, you're missing almost 6 months of sports with turf toe injuries. So those of you that have had this can fully understand the ramifications that these turf toe injuries can bring. So from a treatment standpoint, immobilization, we're looking at boot, cast, bone stimulator, and then ultimately we move into the road of sesamoidectomies. And the hope is that you never get down to this. So these are different incisional placements. The one on the left side of your computer screen is the tibial sesamoid, which we come in from the side. The fibular sesamoid, unfortunately, we have to go in from the bottom of the foot to get that piece out. So the final case I have for the night is a young male football player. He's a quarterback, and he's just kind of had this aching foot pain on the bottom of his foot that progressively has gotten worse, and it's his back foot, so it's his push-off foot. At this point, we've tried and failed conservative care. You see his x-rays up here. Looking at these bones, especially the image on the right or the image of your foot, you can see a clear difference between those two knuckle bones. The one on the inside aspect of the foot is full. The one on the outside, or the fibular sesamoid, is actually cracked in half. And that was ultimately the issue that was driving this athlete crazy. So what we ultimately had to do is go in there and remove the portion of broken bone out of the bottom of his foot. If you see how big these little fractures are, they're actually quite large, 1.5 centimeters. But the good thing that we can report is that about 6 weeks out from surgery, he's back out training for football and getting ready for next season. So I know this is kind of a catch-all. It was kind of a hard topic to walk and talk about because there's so many different repetitive injuries that can happen to the foot and ankle. And as some of the slides demonstrated, the foot and ankle is a very complex issue. And hopefully if there are any questions or concerns, they can be brought in. We do love to hear from all of y'all. And if there is something that's nagging you, we have lots of sports providers and foot and ankle providers that would help guide you and direct you with in-office visits and treatment plans. Thank you. So ankle tendon problems is a very broad topic. A lot of the times, if someone's presenting for the first time with any sort of tendon issue or tendon soreness or tightness, we're looking at anti-inflammatories, physical therapy, activity modification, and some sort of bracing. So yeah, it's kind of a tough question to answer in a very specific aspect, but I just hopefully that broad topic or generalized topic gives you an answer. So Baxter's nerve entrapment can be quite tricky and difficult, and it's actually really quite hard to formally diagnose. So Baxter's nerve is a nerve that comes off of the tibial nerve and goes along the side of the heel bone. And the typical way to diagnose that would be MRI and diagnostic injections. From my own experience, typical cortisone injections are more than sufficient. If that has failed, then I typically recommend either a Baxter's nerve decompression or going in and just cutting the nerve and removing a portion of the nerve. The problem with removing a portion of the nerve is you're trading pain for complete numbness. So once the nerve has been lacerated or cut, it's not going to produce a pain symptom, but you're going to be permanently numb there for the rest of your life. So severities of ankle sprains are very tough to figure out. So there's a grading system, okay, and it's grading 1, 2, 3, and we look at based on the amount of ligamentous damage or damage to the ligaments, which ligaments are involved, and if there's any bony pathology. That's typical diagnosed with someone who sees these very frequently and is able to kind of dig through the slough relatively quickly to provide the appropriate diagnosis and get you going with an appropriate treatment plan. No, they cannot. So what they do is they help maintain the structural integrity of the joint. However, the current bracing, in order to completely restrict you from rolling your ankle, would have to be solid carbon fiber, and at that point it would restrict you so much that you wouldn't be able to function at a high level. So the sports bracing that's on the market is more designed and developed to reduce the risk. However, they're not 100% preventing the risk. Because if we look at the injuries and the amount of force that's driven to sprain the ankle in the first place, it's a high amount of energy. So in my opinion, if you have a Lisfranc fracture or injury, surgery is the only option. And then what you do is you would start to begin the debate between fusion versus ORIF, or meaning putting screws in with the anticipation of taking them back out down the road, or not removing the cartilage. But Lisfranc are very tough, very challenging injuries. But in my opinion, in my practice, these are surgery 100% of the way. Absolutely. There's absolutely risk of repeat ankle sprains. So the way I always describe it to my chronic ankle sprainers is a grade 1 ankle sprain means you stretch out the ligaments. Grade 2 means you stretch it out and tear some of it. Grade 3 means you've totally torn the ligament. And just over time, the more you keep rolling your ankle, the more you damage those ligaments, you damage those tendons, and you can create long-term instability that will ultimately require some sort of surgical management down the road. So for calf and lower leg pain, that typically stems from a tight posterior compartment. So hamstring stretches, basically where you keep your feet together, you bend over at your waist and try and touch down your toes, lengthening out your hamstrings. Calf stretches are something called eccentric stretches, and the way that you can do that is either with a step in your house, like for stairs, you put your toes up on the step and keep your heel down on the floor, and you'll feel a nice tight pull in the back of your leg, up in the calf muscle and up in the back of the knee. They also make devices called night splints that you can wear while you're watching TV, reading a book, working on your computer. That'll help stretch things out. A lot of times some good aggressive yoga, physical therapy, and even a foam roller will help kind of soften up and loosen up tight posterior compartment.